Bismillahirrahmanirrahim. I am Dr. Shazia Sundro. Today we are going to discuss about the enteric fever. So it is, as you know, it's the most common infectious disease endemic in our country, and it is caused by Salmonella typhi, paratyphi A, B, and C. So it is commonly called as typhoid fever. But you know, typhoid fever it is called when it is caused by Salmonella typhi. So enteric fever can also be caused by paratyphoid A, B, C. So you cannot combine both of these in typhoid fever. So it does not completely mimic the enteric fever. So it should be clear. Then when typhoid fever is caused by Salmonella typhi, so it is called as typhoid fever. And when enteric fever is caused by paratyphi A, B, and C, then it is called as enteric fever. It is gram-negative growth. So it is very important to know its bacteriological structure as well as gram staining, because when you advise a patient with suspected enteric fever, so you have to confirm that organism on microscope as well as on cultures. So if you know how it looks like, then you can identify it on your microscope. So it is a gram-negative grout. Its structure is very important. It is covered by a capsule, which is a virulence factor for its survival, and its mutations in different parts, especially in capsular antigen, is very important to be a drug resistant. So it looks like under microscope like this. And when you gram stain, the Salmonella typhi look like red stand, and they are rods. And on immunofluorescence, you can see how their flagella are look like. So you cannot appreciate these type of flagella simply on the gram staining. You have to need a specialized microscope to look for it. So in developing countries, it affects about 100 to 1000 cases per 1 million population. The important thing is the drug resistance, which is very difficult situation nowadays. And the drug resistance is especially to all three primary antimicrobials. So the spread of this infection occurs with direct or indirect contact with infected person. That means that only humans are the source of transmission, especially for Salmonella typhi and paratyphi A. Ingestion of foods or water which are contaminated with Salmonella typhi from human feces is the most common mode of transmission. So in this regard, our sanitary condition plays a very important role in the transmission of the organism. So we briefly look into the pathogenesis of enteric fever. As I have already mentioned that humans are the only reservoir for Salmonella typhi and Salmonella paratyphi A. Salmonella paratyphi B and C, they also infect dogs, cattle and poultry, and they can be transmitted by the eggs or poorly cooked meat. So fecal-oral route is the most common route of transmission, and less commonly the urine of infected person may be the cause of transmission. And the dose, infectious dose, is 10 raised to power 5 to 10 raised to power 9 organisms. The incubation period for this disease is 7 to 14 days, but this is the usual incubation period. But it can be from 3 to 30 days, depending upon the infecting dose. So this is very important slide. We have to see the sequence of events which occurs during the course of illness. First of all, when a person ingests contaminated food or water contaminated with Salmonella typhi organism, so it reaches from our mouths till terminal ileum, where it invades the gut mucosa, and through the specialized antigen sampling cells, they are called as M cells, within the pair patches in the terminal ileum. It is Salmonella typhi is phagocytosed by the macrophages. These macrophages then enter the mesenteric lymphoid system and then passes into the bloodstream via the lymphatics. So this is the main route of entrance into the bloodstream. Here the primary bacteremia start, and then these bacteria are disseminated throughout the body. So wherever they colonize the organ of body, the symptoms will depend on that involved organ. So they involve especially the reticuloendothelial system, in which the patient will have a hepatosplenomegaly. So they replicate within the macrophages and they shed back into the blood. So when first in the primary bacteremia, they disseminated throughout the body and they colonize especially the organs of the reticuloendothelial system, and from that reticuloendothelial system they again enter into the blood, and that at that time they are causing secondary bacteremia. So this is very important, that secondary bacteremia, if occurs, the symptoms are started to develop in the patient. As we have discussed, the virulence factor is a capsular antigen which interfere with the phagocytosis, and a virulence state encoded by the PHOP regulon, which gives ability to survive within the macrophage. So the survival of the Salmonella typhi will be increased after the this capsular antigen which is found in the Salmonella typhi. So it avoids triggering of an early inflammatory response in the gut, and instead colonize deeper tissues or the organ systems and produce inflammatory response in the deeper mucosal layers and underlying lymphoid tissue, which causes the hyperplasia of the pair patches and subsequent necrosis and sloughing of the overlying epithelium. And when you come to know the pathogenesis, then it will be easier to interpret the clinical signs, symptoms in the patient, because when the disease involving the multiple system of the body, then it will be difficult to interpret the different causes of the illness. So we have to be clear in the pathogenesis, how the Salmonella typhi enter in our body, from where it goes to where. So these all are very important. So these ulcers in the gut, they can be bleached, but they can be healed without scarring or structure formation. Inflammatory response or inflammatory lesion may occasionally penetrate the muscularis layer of the gut, and as well as the serosa of the intestine. When they perforate, then when they penetrate these two layers of the gut, then ultimately they results in the perforation. So the mesenteric lymph node, the liver, the spleen, they become hyperemic, they become congested due to the inflammatory response, and usually they have areas of focal necrosis as well, and this all occurs because of the local inflammatory response in that particular system. The mononuclear response may be seen in the bone marrow with areas of focal necrosis. So you see the reticuloendothelial system is primarily involved in the enteric fever and as well as the bone marrow. So these children usually present with the signs symptoms related to the GIT and with related to the bone marrow. Carriers are important, especially in adult group. They are less common in pediatric population. But briefly, we have to discuss about it. The propensity to become a carrier follow the epidemiology of the gallbladder disease, and it increases with the patient age and antibiotic resistance of the prevalent strain. The carriers are generally lower in children than adults, as I have already mentioned. And there are four types of carriers: convalescent carrier, temporary carrier, chronic fecal carrier, and chronic urinary carrier. Why it is important to know all these types of carriers? Because they are main source of shedding of this organism in the specific um, liquid or body excreta. So convalescent carrier are those which passes the bacilli in the excreta from 3 weeks to 3 months after the clinical cure of typhoid. It means despite cure of enteric fever, these patients have carrier. These patients are carrier of Salmonella typhi, and they excrete the bacilli, the Salmonella typhi organism, in their excreta from 3 weeks to 3 months. The temporary carriers are those which passes the bacilli in the excreta 3 months to 1 year after clinical cure of typhoid. So temporary carriers are uh, uh, they can shed the organism up to the 1 year. You see how long they are the main source of spreading the infection. Chronic fecal carriers, they continue to pass bacilli intermittently in the excreta at least 1 year after the infection. So what is the difference then temporary carrier and chronic fecal carrier? The chronic fecal carriers are passing their bacilli intermittently in the excreta, while temporary carriers they passes the excreta uh, continuously from 3 months to 1 year after the clinical cure of typhoid. So this organism can be excreted in the urine. So urinary carriers are those in which the renal pelvis is infected with bacilli, and they pass the organism in the urine. So clinical features are very important to know because when you come into the ward, you come across the many patients with enteric fever, with complications of the enteric fever. So typhoid fever usually manifests as high-grade fever with wide variety of associated symptoms. Associated symptoms are generalized myalgias, anorexia, diarrhea, abdominal pain, and anorexia, diarrhea, abdominal distension. So in children, the diarrhea may be the earlier sign, and it may be followed by constipation. And in the absence of localizing signs, the early stage of disease may be difficult to differentiate from the other endemic diseases. So most common mimicker or most common and close differential diagnosis of the typhoid fever is malaria and dengue fever. So both of these febrile illness also present like this with the fever, the myalgias, anorexia, sometimes diarrhea, vomiting, abdominal pain. The fever may rise gradually, but the classic step-ladder rise of fever is relatively rare. In approximately 25% of the cases, you can find the rose spots on examination, which usually visible around the 7th to 10th day of illness. And these lesions appears in the crops, and crops of 10 to 15 on the lower chest and the abdomen, and they last usually 2 to 3 days. So these lesions are difficult to appreciate in dark skinned children. So on examination, you come across rose spots, which usually are difficult to appreciate in dark pigmented children. You can find the signs of bone marrow suppression in the form of anemia, petechial rashes, and due to reticuloendothelial system involvement, you get hepatosplenomegaly, and generalized malaise, lethargy. You will also come across coated tongue, which is an important sign and which commonly present in patients with enteric fever. So here is a common clinical features of typhoid fever in the children. There is a rate of frequency of involvement of different sign symptom patient, and this study was conducted at Karachi from 2000 children. The common presentation of all the children with typhoid fever is high grade fever, coated tongue, anorexia. These three symptoms are very common, which are present almost up to 90 to 70% of patients. Other symptoms like vomiting, diarrhea, toxicity, abdominal pain, pallor, constipation, headache, jaundice, they present in a relatively less frequency as compared to first three symptoms. So we have to ask all these symptoms in the history, because we have to correlate, and we have to check for the cause of fever in different context of the differential diagnosis. There's a rose spot which I have mentioned, that they look like slightly raised rose red, and which fade on the pressure, and they are usually visible on white skin. So diagnosis. How will you diagnose the patient with typhoid fever? So the ideal and the diagnostic and gold standard is the isolation of bacilli from patient, that is in the form of culture. Culture can be done from the blood, can be done from the stool, can be done from the bone marrow. So the bone marrow culture is the gold standard culture for the diagnosis of enteric fever, but it is an invasive procedure. So most commonly we advise blood culture to be to isolate the organism from the patient. The other investigations to diagnose specifically enteric fever are the demonstration of antibodies in the serum. These both tests are serological investigation, in which first investigation we will demonstrate the antibodies, and on in other tests we will demonstrate the typhoid antigen. So for antigen, the commonly used test was Vidal test, which is nowadays obsolete. And for detection of the antibodies in the serum, the commonly used test investigation is Typhoid, which is also obsolete nowadays. Because of the less sensitivity and specificity, both of these investigations are nowadays obsolete. The one and the only diagnostic and gold standard is the isolation of organism from the patient in the form of culture and sensitivity. Other lab investigation, you can advise for the supportive care of the patient and for the management purpose, and specifically if you are suspecting any complications in the patient. So the other investigations include the complete blood count. Complete blood count may show anemia, thrombocytopenia, leukopenia, and if the patient present with the diarrhea or vomiting, you have to know the electrolyte status of the patient. So you will see the sodium, the potassium, the chloride, the bicarb of the patient. Especially in these children, when they are anorexic, they have poor appetite, they have coated tongue, so uh, they have less food intake and less food intake. So especially they present with the hyponatremia, and again hyponatremia will further deteriorate the condition of the patient, and patient will present with lethargy, and listless, not interested in the surrounding. So renal functions can be done, and liver function test, in which SGPT is important to know, and other investigation if other systems has been involved in the patient. So for example, if the patient present with the meningitis secondary to Salmonella typhi, so you can go ahead for cerebrospinal fluid detailed report, in which for which you have to go for lumbar puncture and the culture of the lumbar puncture test, CSF culture. So any body fluid, if demonstrate the organism that is Salmonella typhi, you can label that patient as typhoid fever. So now come to the treatment. For the treatment of typhoid fever, we have first line antibiotics and other antibiotics. The first line antibiotics include the chloramphenicol, the ampicillin, and the co-triamoxazole, that is trimethoprim and sulfamethoxazole. And these are the first line antibiotics. Other than these antibiotics, we have options of third generation cephalosporin, which are available in injectable as well as in oral form. Quinolone group, which also available in oral as well as injectable form, azithromycin and carbapenems. Carbapenems are only available in injectable form, while azithromycin is only available in the oral form. So this should be clear. If the patient have drug resistance, we have to start the carbapenem group of antibiotic to treat the children with enteric fever. And if the child is can be managed on OPD ground, then you can start the azithromycin in oral form. But if child does not respond to other medication or the culture shows the XDR typhoid, then we have no option than carbapenem. So carbapenem group of antibiotic is very expensive. Treatment of carrier is not important for pediatric population, but only you just come to know that what drugs are available to treat the carrier stage, and it really applied in adult population. Amoxicillin or ampicillin or trimethoprim, sulfamethoxazole, or ciprofloxacin or norfloxacin. Cholecystectomy may be required in chronic cases not treated by the above regime and carriers with polylithiasis. So untreated typhoid fever or improper treatment of the typhoid fever and in the complications, the common complications are hepatitis, cholecystitis. Less common complications are intestinal hemorrhage, intestinal perforation, toxic myocarditis, DIC, and other complications which are not mentioned here are CNS complications, like patient can present with psychosis, meningitis. We have seen children with the age of 1 to 2 months. In these infant age group, the CSF shows a growth of salmonella typhi. So this is very important. If the organism is not treated earlier or in proper dose, then the organism can spread throughout the body and causes complications. So the perforation usually occur in the distal ileum, and jejunum really does not perforate in typhoid fever, and these complications usually occur in the third week of illness. So how will you come to know that your patient have perforation? So when a patient already admitted in the ward with the history of febrile illness, and suddenly your patient develop abdominal pain, severe intensity, abdominal distension, and on examination there will be guarding, tenderness, and rising pulse. So all these signs will direct you that your child must have some complications in the form of peritonitis or perforation. So at that time you have to immediately consult your surgical team and you have to run for X-ray abdominal rate to look for air under the diaphragm. So this is very bad, very dangerous complication. So it is important to prevent the disease rather than we are worried about the treatment. So prevention is better than cure. So how will you prevent typhoid fever? Scrub your hands properly. This is the best prevention. Clean your hands. So simple hand hygiene and washing can reduce the several cases of the typhoid, not only the typhoid but other infectious diseases which we are coming across every day, especially nowadays as you see that coronavirus infection pandemic is also can be prevented by simple hand hygiene. So especially hand hygiene can be offered to um, the people who are concerned in cooking meal. So hand washing, drinking boiled water is very important because we have discussed that the main source of spread of this organism is fecal-oral contamination. And fecal-oral contamination of the water and the foods is very important source of spread of the disease. So we have to drink boiled water. We have to use proper cleaning of the fruits and vegetables because all these are the source of spread of the organism. The vaccine is the best policy to prevent. In recently 2019, with the help of Almighty Allah, the Pakistan Pediatric Association have launched the campaign of typhoid vaccine, which has a good impact for the spread of the disease nowadays. So we are seeing less cases of XDR and VR typhoid fever nowadays, only because of the proper campaign of the vaccine. So you will advise your family members, your neighbors, your relatives, and your other concerned people to vaccinate themselves and their kids to prevent the further spread of this infection. Thank you.